Chapter 5, Medicare Hospital Acute Inpatient Payment Systems. So in this chapter, we're going to be talking about reimbursement for hospitals, for inpatient hospitals. These are our learning objectives. So our Medicare Hospital Acute Inpatient Payment Systems includes reimbursement and quality. We're going to learn about MSDRGs, severity of illness and MSDRGs, the Medicare Hospital Acute Inpatient Systems, and then our value-based purchasing programs as they relate to the acute inpatient setting. Those are our VBPs. These link the quality and reimbursement. We're going to start off, first of all, by discussing some basic terms or some basic concepts. So annually, Medicare does a payment system that they look at for the upcoming year, and they make any modifications or any changes. Any changes are recorded in the Federal Register. This is the official journal of the U.S. government. It is published every day. It reports all regulations and rules, legal notices, anything, not only for Medicare, but for anything in the government. There are people that their job is to monitor the Federal Register on a daily basis to see anything that might be changing. It lists any updates, changes to the payment rates, revisions to covered services, changes to the quality, non-payment regulations. So what we see in there is a three-step stage of that annual payment update. You're going to see a notice of a proposed rulemaking. You can see this here in figure 5.1. This is also on page 88. And this is where it's going to be publicized in advance. Then there's a comment period, and this is where public and interested organizations can comment and provide any relevant information. And then there's a final rule, and this is where we review those comments, and then we make a publishing of that final rule with analysis of the comments and info where we've taken into consideration any of those comments. So just to kind of summarize, and important to know, for prospective payments, the payment rates are established in advance of the healthcare delivery, and they are fixed for the fiscal period to which they apply. So there's a fixed payment that's going to be for that updated year that is coming, and those are going to be found in your Federal Register. When we finish with our lecture, I'm going to show you the Federal Register just so you can see what it looks like. Now, a Medicare cost report. This is submitted to our MACs. A MAC is a Medicare Administrative Contractor. They are the contracting authority that administers and processes Part A and Part B claims. They do this for hospitals, skilled nursing facilities, renal facilities, hospice, home health, health clinics, community mental health centers, federally qualified. They do not do that for physicians or ambulatory surgery centers. They have a form that's going to collect that information to determine anything that is payable under the PPS system. So when they submit that information, they're looking at the characteristics of the facility, any utilization data, cost and charges by the cost center, Medicare settlement data, financial statement. So they use an approved software. They have to file it within 5 months of the end of the fiscal year. It's submitted to the MAC. It's maintained in HCRIS. HCRIS is the Health Provider Cost Reporting Information System. And then that data is used by CMS for research, and it's something that other facilities could also download from CMS if they were trying to come up with their cost report, if they wanted to compare cost. Now, CMS has a vision for healthcare quality that all persons receive equitable, high-quality care. So they came up with the basic Medicare value-based purchasing, or VBP concept. And this was a way for CMS to define the health outcomes to improve quality and transform the whole system. It provides better care for individuals, better health for the population, and it did lower the cost through improvements to care. There are 8 goals of that CMS quality strategy, and this is what links the quality to the reimbursement. So it must be embedded quality into care journey. So the quality must be optimal. Advanced health equity, so it should be the same care for all. It should promote safety by preventing harm or death because of healthcare errors. It should foster engagement, and that's between the providers and the individuals. So it kind of gives a voice to the patient and allows them to be able to communicate more with their care team. Strengthen the resilience of that healthcare system. Embrace the digital age by having seamless communication, interoperability, standardized data sharing. We still probably haven't got there the best that we should, but that is something where we're still working. It incentivizes innovation and technology. One way that we do that is with telehealth. Increases the alignment so that the payment across all services is more simplified and national rather than just local. So the CMS VBP program links quality to reimbursement. It pays for reporting, it pays for performance, and it pays for value. So we develop quality measures as the first step, and a measure is some data that can be quantified. And so we determine those performance measures that we want to look at, and they can change. They may not be the same from year to year. So we pay for reporting the program for the Medicare system, and CMS allows facilities to maintain full payment if they successfully participate in the program. So table 5.1 is on page 91 in your textbook. And that just kind of shows you some of the incentive reports and what needs to be, where they report and what law requires it, and then what penalty would be there if they didn't. Now, one thing that they do require is that they have to pass validity at a minimum of 80%. So that's not something that Medicare just takes lightly. They do come back and check to make sure that the information has been submitted correctly. Now, our inpatient services, this is for our acute care facilities. It's also known as the Medicare IPPS. It provides payment to the facilities, but it does not include the payment for professional services. So that's important to note, that this system is only looking at paying the facilities. The doctors will have to report their self somewhere else and receive payment elsewhere. This is only paying that facility and that inpatient care. So this uses case rate reimbursement, which we're going to talk more about some of these as we go through this chapter. It does exclude psychiatric, rehabs, long-term care, It also excludes cancer centers and pediatric hospitals. It is the Alliance of Dedicated Cancer Centers are exempt, and it is reimbursed via a reasonable cost. And our federal fiscal year is October the 1st through September the 30th. Now, we use what's called the Medicare Severity Diagnosis Related Groups, or MSDRGs. These organize inpatient admissions into larger groups for reimbursement. So as our admission starts, that's our formal admit when we get doctor's orders, and it ends with that doctor's discharge order. That's what we count as our inpatient admission. It groups patients with like resource consumption. That is, how much resources are required to treat that patient, and LOS patterns together. Now, LOS stands for length of stay. We use MSDRGs to look at hospital composition of patients, and that influences our cost. So there's three parts that we look at when we're looking at MSDRGs. We're looking at the relative weight, the case mix, and the case mix index. Our relative weight represents the resource intensity of that group. Each MSDRG has used to determine a payment level for that group. So it's a number that we use, and you'll see as we get further along, we're going to talk about some formulas. We actually use that relative weight as a multiplier to determine how much we'll get paid. Case mix is the complexity or the description of the patient population, and that can vary by the healthcare perspective. And then our case mix index is a single number. It's a weighted average of the sum of all the relative weights of the patients during a specific time period. So it's a single number, but it compares the complexity of the patients in the organization. So it's usually the MSDRG weights divided by the number of cases that facility may have. The patient population is described by its severity of illness, risk for mortality, prognosis, and the treatment difficulty. The system takes into consideration the role that a hospital case mix plans in influencing the cost for that facility. MSDRGs were the first system to allow the measurement of a hospital's case mix complexity. It's a direct measure of the resource consumption and therefore the cost of providing care. A hospital with a complex CM means that the hospital patients are consuming more resources and therefore the cost of care is higher. So a high case mix means the patient consumes more resources, so their care is higher. So just to kind of keep straight in your head, important to know, case mix index means the same as consumption of resources. If we're using more resources, we're using more supplies, whether that be equipment, personnel, then it's going to cost more to care for that patient. So a fully packaged system has one MSDRG that's assigned per encounter. And you can see there it shows you what would be covered. The facility costs, the pharmaceutical supplies, nursing. Remember, it does not pay for that physician hospital visit. That's covered elsewhere. Doesn't fall under the MSDRG. It doesn't play a role in our payment to that facility. You can only have one MSDRG assigned per encounter. It is prospective, and the facility again accepts the profit or loss. So you can see there, if we go above the average treatment, then we're going to have a loss. If we are under that, then we will have a profit. It kind of drives facilities to practice cost management based on what would be considered the average cost for an average patient. Now let's talk about how these MSDRGs are structured. And this is also on page 93 in your book. This is figure 5.2. So we kind of have three levels of our DRG. It is set up as a hierarchy. The highest hierarchy is that orange box, major diagnostic category. That's what MDC stands for. Major diagnostic category, and it is the highest level. It's our first level. Next, our second level is that MSDRG surgical or is it medical? And then lastly is our third and final level, which is where we break it down more specifically. So in your textbook on page 94 are listed the 25 major diagnostic categories. So those are the 25. You can see that they are listed pretty much by the body system. There are some as you get to the bottom that are more broader. So 5.2 table on page 94 is a list of the 25. Then we've got surgical, medical. And then over on page 95, table 5.3, it kind of shows you that third and final, which we're going to talk more about, where you can see it's broken down with a little bit more specific as far as like A, B, C, and D. We've got some widths, and withouts. But that's the hierarchical system. So MSDRG up to 25 diagnoses. Looks at your discharge status, your age. Looks at procedures, male, female. So what do we see when we look at what are the pieces and parts of our MSDRG? We have a group number. We have that MDC assignment. That's our major diagnostic category, pre-MDC. Is it medical? Is it surgical? That means did it have a surgery involved with it, which would be a procedure? The title of it, LOS is our length of stay. We have two types. We have the GMLOS. That's the geometric mean length of stay. That's the nth root of a series of n length of stays. This is less influenced by outliers. We have the AMLOS. That's the arithmetic mean length of stay. Sum of all the lengths of stay in a set of cases divided by the number of cases. There is example 5.1 on page 93 that shows you how they calculate those three. You don't need to get hung up on that. Those aren't things that we will calculate. Then you have your relative weight. Remember that that is our consumption of resources. And then we have a code range that drives that MSDRG. So this is figure 5.3. It's on page 96 in your book. So this is MSDRG 293, heart failure and shock without complication or major. You see that our geometric length of stay is usually 2.1 days. Our arithmetic is 2.5. Our relative weight is 0.5603. Our principal diagnoses could be any of those ICD-10 CM codes that are listed there. They would fall in that MSDRG. Now we also have, and this is how we get to that third row there, our third level of hierarchy is looking at the severity of illness component. This refers to the extent of the physiologic decompensation or organ system loss. MSDRGs use secondary conditions to establish the severity of illness. Complication, comorbidity. Complication, these are CC abbreviations. They are reported with your ICD-10 CM codes. A complication, definition, medical condition arises during the hospital stay that prolongs the length of stay at least 1 day in approximately 75% of the cases. Comorbidity is a pre-existing condition that, because of its presence with a specific diagnosis, can cause an increase in length of stay by at least 1 day in approximately 75% of the cases. And again, these are going to be, you'll see these in your ICD-10 CM book. So we end up with 3 levels of these secondary. We end up with an MCC, which is a major impact, a CC, which is a moderate. That's anytime we have with CC. And then we have 3, which would be a minor, which was where there's no CC and no MCC. So if I go back in your textbook to table 5.3 on page 95, you'll see that there is MSDRG 194, simple pneumonia and pleurisy with CC. That would be a moderate. 291, heart failure and shock with MCC would be a major. And 293, heart failure and shock without CC or MCC would be that is a minor. There's no CC and no MCC. So that's how they would read if you were looking at them in a table. And that's looking at table 5.3 on page 95. Now, the MSDRG families with the examples, that's also listed on page 96. The CC is looking at your diagnosis codes, and what happens is by having that CC and that MCC, it increases the severity. So it means that we're using more resources to care for that patient. So the highest level would be an MCC, which means we're going to get the most reimbursement because we're using more resources for an MCC. So just keep in mind when you're looking at those secondary codes that you make sure that you are following those definitions and assigning them properly, because it could lead to loss of money or reimbursement for that facility. All right, so this is how we assign our MSDRGs. So there's 4 steps. We first of all go through pre-MDC assignment, then the MDC assignment, surgical or medical, and then we refine it. Now this is a 4-step process, and you do need to know each one of these steps. You need to know the name of them and kind of how it goes through. There are some scenarios on your test where it's going to say which of these steps are you in. This is what you've done. What do you do next? So make sure you know that. In reality, we probably have a lot of groupers, and those groupers take us through these ourselves. Our encoder that you've used in the VLab kind of helps us with this as well, with some of the questions that it's asking. And figure 5.5 on page 97 kind of shows you how it takes you through each of those steps to assign that MSDRG. So step one is the pre-MDC assignment, and there are 15 MSDRGs for which the MDC of the principal diagnosis is not taken into consideration. These cases are directly assigned based on procedure codes only. The resource intensity of this procedure drives the assignment for these. So, for example, the diagnosis for mechanical ventilation is no concern. The fact that the patient was on mechanical ventilation for more than 96 hours drives the resource consumption and therefore the MSDRG assignment. So with this is based on ICD-10 PCS codes, these 15. Once you choose this, then you don't have to go any further. This is it. This is where you can stop. You don't have to go past anything else. Table 5.4 on page 98 shows you these pre-MDCs. So if it's any of those, then that's where we stop. We don't have to go any further. So if it meets step one, and we can say yes, we stop, we're done, we don't have to go anywhere. But if it's not one of those 15, then we're going to move on to the next step. So here's an example. A pancreas transplant can be performed for a variety. And this is example 5.2 in your book, page 99. A pancreas transplant can be performed for a variety of clinical conditions. The diagnosis that warrants a pancreas transplant can be found in multiple MDCs. There's only one MSDRG for all pancreas transplants, regardless of the principal diagnoses. Thus, the patient who received a pancreas transplant would be assigned to MSDRG 010, regardless of the principal diagnoses. And it lists there on page 99, it shows you some other things that can cause you to need it, but that doesn't matter because we have that as a MSDRG. So our step number 2, this is where we determine the MDC. So what is the MDC of the principal diagnoses? Our principal diagnoses, remember our definition, established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. This is our ICD-10-CM. There are 25 of those, and they are based on those body systems. That's what we looked at, table 5.2 on page 94. So, example 5.3 in your book on page 99. Patient A presents and is treated for pneumonia caused by strep group A. The case is assigned to MDC-04, diseases and disorders of the respiratory system. It says group A strep pneumonia is a respiratory disease, therefore, and we're going to go back and you can see there is only one MDC for respiratory. Now, why would I not pick MDC 18? It says infectious and parasitic diseases, systemic and unspecified sites, because it specified that it was pneumonia, and pneumonia is in the respiratory system. So you got to kind of have to think about your diseases and where they are. If you don't know, grab a dictionary and look it up. Next, step 3. Is it medical or is it surgical? Was an operating room OR procedure performed? If yes, it's surgical. MSDRG manual specifies which procedures are considered OR procedures in the Appendix E of your MSDRG definitions manual. If no, it's medical. If it's a minor procedure, then that doesn't qualify. It can be primary or secondary. And then your ICD-10 PCS shows you which of those codes are valid or not valid that can be used. So example 5.4 in your text, again, we're on page 99. Patient A presents and is treated for an acute myocardial infarction of the anterior lateral wall, initial episode heart attack. So the MDC 05, diseases and disorders of the circulatory system. The PTCA code is a valid OR, thus this is a surgical case in MDC 05. Like patient A, patient B is also evaluated for acute myocardial infarction of the anterior lateral wall, initial episode. So we again assign MDC 05. There was no procedure, so this is a medical MDC 05. Next is our refinement, step 4. This is where we're going to ask a lot of questions. And this is where we're going to refine it and make sure that we get that right. CC, MCC, or whatever we need there. So these are some examples. Is it a major complication or comorbidity? MCC. Is it a CC, something that's secondary? Did the patient have an acute myocardial heart failure shock? Did the patient coma last, if they were in a coma, last more or less than an hour? Was it performed for a neoplasm? What is their sex, male, female? What was the patient's discharge disposition, alive or expired? Remember that if there is a CC or an MCC, then they used more resources. So this patient is example 5.5 in your textbook, page 100. So patient A is 67, admitted for a duodenum fistula closure procedure. So that's going to put him in MDC 06. The fistula closure is an OR procedure. Is there an MCC? No. Refinement, is there a CC? Yes, they had osteomyelitis of the vertebra, which is a comorbidity. So we're going to assign them 327 stomach, esophageal, and duodenal procedures with a CC. Now, I would know that, so in my textbook, it tells me that the patient also has osteomyelitis of the vertebra. So this is just pulling out those pieces to kind of show you, so make sure you read the entire examples. Now, how do I know that it's a CC? Remember that whenever I code that osteomyelitis of the vertebra in my code book beside it, it's going to show me that. Example 5.6, also on page 100. Patient B is 68 years old and is admitted for cellulitis of the right ankle. So I need to know that cellulitis is part of my subcutaneous tissue. So let's see, they did a non-excisional, so they did not go to the OR. How do I know that? If I don't know, I need to look up what does non-excisional mean. So break that word down. Excision would mean that they cut it. Non-excision would mean that they did not cut it. So if they did not cut it, they didn't go to the OR. So it said, is an MCC present? No, COPD is not an MCC. And they didn't have any other conditions. So they're going to get the cellulitis without MCC. Now, there are some exclusions. There are principal diagnoses that can take away that power of CCs and MCCs. They are closely related to the CCs or the MCCs, so these are conditions that are not expected to increase the length of stay of resources, and they're not used because they're not going to assign a higher weighted MSDRG. There's also two DRGs which are invalid, MSDRG 998. This shows that an invalid diagnosis was used, and principal diagnosis is not specific enough. And then MSDRG 999 means that it was ungroupable. Invalid diagnoses, code, age, sex, or discharge status. So that means that something either was not coded correctly or there wasn't enough information. So payment for both of these DRGs would be 0, and those are going to be sent back. And when they are sent back, then that gives you the opportunity to make corrections and then resubmit. All right, so before we go ahead, I want us to look at a couple of things. So this is our MSDRG. Let me find the right one. That's not it. So you can see on the CMS webpage, there's a lot of information that we can go to for our information. Trying to find. This is one example. And I may have to do a second video where I actually have uploaded the file. You can see where they already have the draft file for next year in here. Let's see if it'll let us look at next year's. Okay, let me just kind of show you this page just a minute while we're here, and then we'll. So this is our MSDRG page for our and you're going to see we're going to talk about some of these items. Let's look at this. So you can see we've got all of these different terms, and we're going to talk about a lot of these different terms in our next section. But this is where, if you were working in field and you wanted to come and see final rules, this is where you would come. Let's go to the Federal Register. So here's our Federal Register, and this is Daily Journal of the U.S. Government. So let's type in Medicare, and let's look at the past 30 days. So you can see we've had a notice, 32 notices, 14 rules proposed for, and a presidential document. So this is where you can go in and you can look, and you can open all of these, or I can come up here. Let's find a proposed rule. So if you're a Postal Service Health Benefit Program, look at this one. Let's look at this one, because I know this one a lot of people have talked about. So this one is Schedules of Controlled Substance. Addresses handling, and you can see, you can come through and you can see all of the information that there is. Here's about the hearings you wanted to find out about. Legal. I can come here for the Centers for Medicaid. So this is about organ transplant access. Proposed rule. Incentives being paid for an increased access to kidney transplants. So here's where you could submit comments. You can mail them in. Tells you kind of the purpose, a little bit about it. So this is the Federal Register. And I'll do a separate video with some MSDRG information. So if you're a little confused about that, I'll do another MSDRG one. All right, let's finish with our lecture. So I went too far. So with our IPPS provisions, it does provide additional payments for specialized programs or for unusual admissions that have in the past cost more money, and because of that extra cost, it may have led to a facility not wanting to provide that service. So these a lot of times are called outliers, and an outlier is a hospital's cost for a case that would exceed the threshold limit that has been established for that fiscal year. So every year they establish that amount of that payment, and remember, it can't be changed for that fiscal year. So there are some times when they say this is an extreme case, it's going to cost us more to care for it. And in those cases, that extra money or additional payment is going to be given to that facility. Now, it does not mean that the facility will not still lose money, but what it does mean is that there is a chance that they may not lose as much money as what they would have lost. But it doesn't mean that they get it 100% paid for because of it. So the estimated costs are compared, and they pay an additional amount of money to that fixed amount. So it's kind of like an adjustment. The additional payment amount is equal to 80% of the difference between the hospital's entire cost and that DRG payment plus that threshold amount. So again, 80%, it's not saying 100%. So there's still going to be some amount of payment for that facility. Now, there are some adjustments that can be added to that. And one adjustment is an indirect medical education, IME. And this is where we give a percentage of money if it is a teaching hospital. Studies have shown that with a teaching facility, it does cost more money to teach residents than it does for a non-teaching hospital. And that's an IME adjustment. A second type is a disproportionate share hospital, or a DSH. This is for a hospital that meets government criteria for care, that they have a high number of indigent patients. So they get an adjustment that helps cover costs for those patients who are unable to pay. And then there is also a new technology, which is where they get an additional payment to cover the cost of that new technology that's being used. So that new technology ensures that new and innovative services are provided to those Medicare beneficiaries. New technology simply means that there's clinical improvement that helps utilize that technology that without an extra amount of money may not be used. It is an additional payment. You do have to apply for it. They submit a formal request with a description and kind of explain why it would be better. A lot of times with this, they get the full DRG plus up to 50%. And again, not a complete 100%, it's 50%. The cost limit is established for each service or piece of technology. And again, this is going to be published in the Federal Register where we just looked at. Providing these services, again, could be where patients might not be able to receive that service if that facility did not receive that extra money. So here's an example. Cosela, which is trilaciclib. It's used for people who have extensive stage small cell lung cancer and are receiving certain types of chemo. Cosela helps with the myeloprotection. Myeloprotection means helping protect from blood-forming cells in the bone marrow from harmful side effects. The maximum add-on amount for that is $5,612.10. The PCS codes there are XW03377 and XW04377. When those two codes are input, then it automatically activates that add-on payment of the $5,000, $612.10. That's going to be added to that base rate. Makes you wonder how much that medicine actually cost, if they're getting a partial percentage of it. So that's an example of that. And then another provision is the transfer cases. Now, when we talk about transfer cases, this is patients moving facilities, and this is when they go to different facilities during their course of care. So we have two types. The first type is a transfer between two IPPS hospitals. So acute care, they're discharged and admitted to another on the same day. One example of that could be AMA, which is against medical advice. Not always, but that's just an example. Second is a transfer from an IPPS hospital to a hospital or hospital unit that's excluded, which would be like a non-acute inpatient rehab, long-term care, psych, cancer hospital, or children's hospital. Now, before we talk about a PAC policy, let's look at the next slide. This breaks down those types again. So type 1, this is how they get paid. The type 1, remember that's between two acute cares. The transferring hospital receives a per diem amount, and that's determined by taking that MSGR rate and dividing it by the geometric length of stay. It's double the per diem for the first day and then single after that. The receiving hospital is going to get that full MSDRG payment. Type 2, Transfer and hospital receives the full PPS payment, and then the receiving hospital receives their full payment that's applicable. So whatever it is that their payment type is, then they're going to receive that type. So type 1 per diem, and then full for whoever gets them. Type 2 is full for that hospital, and then the other one goes to whatever their payment system is. Now let's go back. A post-acute transfer or PACT, and you need to know what a PACT is, and you need to know what a type 1 and type 2 and how they get paid, just saying. A post-acute, it's designated MRGs that treat a type 1 like a type 2 for certain ones. So there's certain MSDRGs that they treat a type 1 like it's a type 2. That way that everybody gets paid. Now, let's look at figure 5.6 on page 103 in your book, and that kind of summarizes the outlier, the new medical services, and then it also shows you the transfer cases. That's kind of just a summary and a breakdown of how those are. All right, our base payment rate. So it's per admission amount. It's adjusted for each hospital. It's published each year in the IPPS final rule. There are 2 parts. Know those 2 parts. The labor is about 70 to 75%. That is the wages, the salaries, the employee benefits, professional fees. Non-labor is the facility operating cost. How much does it cost to run that facility without the labor? Now, our base rate is going to be adjusted with hospital specific. It's going to look at the wage index, which is our geographic location, cost of living if applicable, that disappropriate share, remember that's our indigent care, indirect medical if applicable, remember that's if it's a teaching hospital. Those last 2 there are those additional payments that are going to be added to if needed. So the wage index is the ratio that represents the relationship between the average wage in a healthcare setting's geographic area and the national average. It adjusts the lab-related share of the base rate. It adjusts annually, and it's going to be published in the Federal Register. COLA, cost of living, reflects the change in the Consumer Price Index, which measures purchasing power between time periods. It adjusts the non-labor share, and it is applicable for those that live in Alaska and Hawaii. So there is formulas for both of those on page 105, figure 5.8 and figure 5.9. Don't get hung up on those formulas. Those are going to be given to us. We don't have to calculate those. Next, we have our DSA and our IME. Remember, DSH is if we have indigent patients, we're going to receive that extra percentage of payment. And our IME is going to be when we have those teaching facilities, we get a percentage of payment based on our residents and the number of hospital beds. And those are going to be our adjustments. So figure 5.7 over on page 104 kind of showed us the whole breakdown where we get our geographic factors, then our case mix, and then our policies, and then our adjustments, and it kind of shows you how you get that whole payment. So simply put, to get our reimbursement, we need two things: our fully adjusted hospital base rate, and then we need our relative weight. We multiply those together, and then we add any of those extra payments, and that's our reimbursement. So let's look at example 5.7 in our text. It's on page 105. So patient A was treated for a hip fracture and an OR procedure. MSDRG 470 is assigned. The relative weight is 1.9119. The fully adjusted base rate for the hospital is 7325. The RW is multiplied by the hospital base rate to calculate the estimated payment rate. The estimated payment rate is $14,004.67. All we did was multiply those two. And then patient B in example 5.8. Let's see, they were assigned 293, non-OR. RW is 0.5603. The fully adjusted base rate is 7325. We multiply those two. Fully adjusted, all adjustments added. So if it's fully adjusted, everything has been added. So let's look at check your understanding on the bottom of 105. The quality reporting program. What is CMS's quality reporting program? That's our VBP, where it helps to increase the quality of care. The steps for our MSDRG, remember we needed to know those. So we start off with, the first thing is we have to look at, can we assign that MDC? Then we decide, is it, well, first of all, is it one of those 15 that are pre-MDC? So pre-MDC, MDC, is it surgical or OR? And then lastly, do our refinement of it. Our refinement questions, is it an MCC? Is it a CC? If they've been in a coma, remember those questions, know those questions. What does the labor-related share of the standardized amount represent? Remember that the labor share is the employee cost. So it's talking about our professional fees, salary, benefits, employee benefits. What is the formula for the basic IPPS? That is our relative weight times the base rate plus any of those provision payments. That's right there on our slide. Remember, if it's fully adjusted means that those provisions have already been added to it. So we could say our MSDRG times our fully adjusted. All right, I think we've looked at all of those. All right, last part of this chapter talks about our VBP for the hospital. So the Medicare decided that they would establish a hospital VBP program for quality reporting. And over time, what's happened is on page 106, you can see where all of those since 2012, they have been added for each one of those facilities, these quality programs. Now, what they found was, though, that the hospital was the place where we paid the most money as a CMS group. So they had to come up with a way that they could control the cost. So they did that with withholds. Withhold is a portion of the facility payments that are held back and then redistributed based on the facility's performance for the quality measures. So it's usually a 2% withhold, and then based on the total performance score, they can get that money back, that 2%. So really and truly, they can get anywhere from 98% of the payment up to 103% of the payment. There are 4 domains that are looked at and measured: clinical outcomes, person and community engagement, safety, efficiency, and cost reduction. With that, what they do is they look at the performance achievement, comparing it to other facilities, and then performance improvement, comparing performance to their baseline to see have they gotten better. Each one of those domains is given a percentage, and then it's weighted and given a score. And that score is then transferred to their TPS. So on page 108, figure 5.11 shows a quality reporting score for a facility that shows what domains and what areas a facility or hospital is doing the best in, where they can improve. And that is then reported. And it shows that weight of that domain and what areas they're doing really good in and what areas they need improvement. Like that area looks like they need some help with safety on page 108. And then you can see figure 5.12 on page 108. It also shows you how they are getting their money back, anywhere from 98 up to 103, as far as getting their full percentage back. Now next we have the hospital acquired and present on admission, HAC and POA. POA means present on admission, which means that it was present before, and HAC means it's hospital acquired condition. It developed during that hospitalization. This reduces payments for conditions that are hospital acquired. Reduction is on a case-by-case payment, and it is paid at a lower severity when the HAC is reported. So hospitals have to submit on their UB04 a POA indicator that says whether or not a condition was there. There are 14 categories. They are listed on page 109. When conditions are the only MCC or CC present, that's when they apply. If there are additionals on the claim with it, then it may or may not even affect the payment. It just kind of depends. It does use the ICD-10-CM diagnosis codes. We have the Hospital Acquired Condition Reduction Program. This provides payment incentives to facilities who are reducing their HACs. So facilities with HAC scores in the lowest performing will have payments reduced by 1%. So we look at 2 domains, and this is from 2020. So 15% came from those patient safety and adverse events, and then 85% came from the green area. These are areas that we track for the CDC and the National Healthcare Safety, which looks at healthcare associated infections. The patients then receive a score, And based on that score, then each facility can report. They get a copy of that report. If they question it or feel like they need to make changes, then they can make changes and resubmit it. Another program is the Hospital Readmission Reduction Program. This is when there's an encounter for readmission when a patient comes back within 30 days of discharge from the original admission and the admission is not a planned readmission. So in this case, hospitals can have up to a 3% reduction in their PACE amount for all admissions during that payment year. So basically, this is for patients that are discharged too soon. And it's a way of not releasing patients too soon when a facility may be at risk for losing money. There's 6 conditions right now for fiscal year 23. We had acute MI, heart failure, pneumonia, COPD, total hips, total knees, and then CABG. CMS can change these whenever they look at it from year to year. There are also other conditions that oftentimes they will look at if the patient has been readmitted quickly. Okay, so let's now go to the patient connection. So this is our little patient. This is on page 112. So let's see. Malachi has played basketball his whole life. He spent 20 years coaching high school. Over the past couple of years, his right knee pain has been more intense. He's starting to show a limp. He's having right knee arthroplasty. Significant issues, unable to pass in hospital. Transferred to a skilled nursing facility. So he got MSD 470 major hip or reattachment without an MCC. The cost was $18. They will not reimburse over. So it cost more, so they had a loss. And the hospital is responsible for that. So they're not going to reimburse for that, and they cannot bill the patient for that. Difference, what is it, about $5,000? $5,500. All right, then we have Olivia. So Olivia is ready to deliver her baby. SuperPayer uses the MSDRG calculation system as a basis. So she's got 807 vaginal delivery without sterilization, without CC or MCC. Let's calculate the estimated reimbursement. The calculation. Okay, so let's multiply. 0.6268. 0.6268 times 10. 125.50 equals. The estimated reimbursement for this is $634,666. Okay, so according to the book, it says the base rate negotiated was $10,125. So in this case, they made a profit. On that one. All right, so let's close this. Now then, let's come back here. Let's go and let's look at some of our others. All right. So this is another slide that's in here. We've got some terms. Grouper, it's got our MCC, major. Remember, that's our highest level. Here is our MSDRG, principal, relative weight. Here's our steps. Know those steps. Shows you where to go. What text, what tables. The next step. And then our refinement. There's just some questions. Remember, there's our without, 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 with. Go through and you can look at the different steps of those. So there's our multiplying. How do we get that rate? All right, there's that one. So now then, let's go back. Let's do this. I like these. These are great little reviews. So here's our cost of living. Lots of terms in here that were great terms. Know these terms. This was in your text. Here's that example of that Casella. What PCS codes. Here's those weights, geometric. Here's some examples to take you through. Some of those terms again with some examples. The base rate. All right, now then, the last one is about our VPA. Hospital acquired, there's those measures, performance achievement, POA, there's your total score, what a withhold is, the 4 programs, the VPB, HAC, that reduction of the HAC, readmissions, how they withhold. There's that table to kind of show you less than 2. Some can earn more than 2. Most earn back the 2%. What is a POA? What is an HAC? Just lots of good definitions in these. All right, and then a couple of things that I really like. Here's some instructions about the encoder. So with the VLab, this takes you through how to set up your VLab. I wish we'd have had this for the VLab. And it shows you putting in your diagnosis code, and you can go through step by step, add your diagnosis to where you get your DRGs, shows you your different examples. This is just a really good, and then it's got some scenarios that it takes you step by step through. So look at the using the encoder first, and then there are some examples that you can practice with your VLab. Some patient scenarios that you can use with your VLab. So that's a great example there. So now, let's look at your homework course. Okay, the assignment consists of 10 inpatient care admissions, 5 community, and 5. Complete the MSDRG. Notice the fully adjusted charges are different for each. Remember that the fully adjusted, all right, answer the 4 questions. So let's open it up. MSDRG calculations. So it does give us an example. MSDRG, the cost of the encounter. Subtract the cost from the MSDRG to determine the profit and the loss. So here is an example of one. Here is our base rate. Here is our RW and our charges. So let's come right here and let's do our math. So how did we get this 4,000? We multiplied the fully adjusted specific base rate. That would be 6,200. 2. Maybe it's going to let me. Six 200 times, what was my relative weight? 0.7007 equals 6200 times 0.7007. This amount right here. That's how I got this number. So I multiplied this times this, and I got this. Okay, now then, it says multiply the charges times the cost. So I'm going to say 9456.82 times 0.429 equals 9456.82 times 0.429 equals this number right here. Okay, so is everybody with me? Multiplied these two highlighted, got this. Multiplied these two highlighted, and I got this. Now, how do I get to this? I'm simply going to subtract these two. So I say 4344.34 minus 4056.98. And I get this one. Okay, so does everybody see? Now let's do a real one. So let's come over here and let's do this one right here. So my reimbursement is going to be 6,200 times So I say 6,200 times 0.6418. So I'm going to say 6,200 times 0.6418 equals 3979.16. Okay. Now, here I'm going to say 15,123 times 0.429 equals so 15,000 times 0.429 equals 6435. So now I'm going to say 6435 minus 3979.16 equals, so 64 All right, so that's how I got that. Let me check my math now, make sure I did my math right. $15,000 times 0.429 equals 6435 minus 3979.16 equals 245584. All right, so in this case, this is a profit. Now, I put profit here, but you can also take this and you can put this in parentheses if you want to. That's another way to do it. Either way you want to do it, whichever makes sense to you. Make sure you look. Calculate the DHR. Remember that the hospital includes adjustments. Once you've completed, then we're going to come down here and you're going to answer these questions, okay? Make sure you're double checking because these are different from these. So don't just assume. You have 1, 2, 3, 4, 5, 6, 7, 8. So that's those. Don't save those. All right, that is the... All right, then we have our estimated diagnostic groups. Let's look at this one. All right, so in this one, administration wants to know the estimated MSDRG payment. The grouper on your information system has crashed. Oh my goodness, I hate it when that happens. Administration needs this information immediately, so you need to calculate the payments manually. The add-on percentage for your healthcare organization is 2. The hospital's base rate is 7. The MSDR that administers is concerned about, the MSDRGs that administration is concerned about are shown in Table 1. So, first of all, Table 1, we have our MSDRGs there. So what I would probably do is go down there and I would probably look and see if my what my MSDRG is. So let's do 190. So 190, my MSDRG is, I'm going to copy it. And I'm going to paste it right here. That works better if I open it up like that. All right, so now how do I pay? All right, so it's telling me there about my add-on percentage, right? So let's think about, what does my add-on percentage mean? My add-on percentage, if I go back to my notes, my add-on percentage was based on if I met certain criteria. Do I have enough information to see if I need that add-on percentage? Just with what I have here, do I have enough information to do that? So let's go back just a minute. Let's close this. And let's go, well, let's leave that open. And let's go back to our book. So our 2% add-on came with let me get you to the right page. Our 2% add-on came with our adjustments. With our hospital VPBD for our total performance score. So do I have enough information about that to be able to put in my total performance score? I do not, because I don't know what my total performance score is. So in that case, all I am doing is multiplying my relative weight times my base. So I'm doing 1.1743 times 7320.50. And that would equal 8596.46. So all I'm doing is just my basic. Don't let that add-on percentage. Now, if I read it as this and they're telling me that that the facility does have that add-on, this could also be true. I could say that times 0.02 would then give me an additional amount of $171.93. So if you get hung up on that and the wording is just, well, I just don't know, Miss Davis, if that's right or not, I could say that, yes, I see your point. It is kind of vague, and I would give you credit if you also went in and added that 2% to it. And adding that 2% is just simply adding that additional 2%. But remember that what you're doing is you're adding that 2% back to your base pay. which gets kind of confusing. So what I suggest is we just do it this way. Let's make it easy. All right, and you're going to do that for the rest of those. All right, that's it for Chapter 5. I will do another MSDRG where I'll pull up that table to show you a little bit about the MSDRG table, and I'll get that one uploaded today. Good luck with Chapter 5.